everyone. Thank you for sticking around for this. I'm excited to talk about healthcare with all of you and with our wonderful panel. I just want to start by introducing all of them. So to my far left is James Capretta, who is a resident fellow at the American Enterprise Institute. In the center here, Sherry Glied, who is the Dean and Professor of Public Service at the Wagner School at NYU. And sitting beside me is Steffie Woolhandler, Distinguished Professor of Public Health at the City University of New York at Hunter College. And really excited to talk about Medicare for All, which I have enjoyed covering because it is an idea that felt, even just a few years ago, to be sort of on the fringes of our political conversation, and all of a sudden feels very much front and center in the Democratic presidential debate, where we see Elizabeth Warren, who seems to be, the top, if not the top candidate right now, really embracing a Medicare for All platform, but lots of other Democrats all over the place with different proposals that are more moderate, I would say. So let's get going. So I wanted to start by asking all of our panelists, when they think about the US healthcare system, what are the biggest problems? What is the thing that is wrong with our system that public policy ought to be addressing? And I suspect that each of you will have slightly different solutions to that problem, which may or may not be Medicare for All, but just because not everyone here is a healthcare person, why is it that we need to be having this conversation about doing something different than what we do now? Steffie, you want to start?
Sure. Well, as we speak, there's 30 million Americans who have no health insurance of any type. And those people are sicker and they die younger as a result of being uninsured. An additional 20 to 30 to 50, depends on the estimate, million people are underinsured. That is, they have health insurance that they can't afford to use because of co-payments and deductibles and uncovered services. And this has severe financial consequences. Medical bills are one of the leading causes of personal bankruptcy. They're also the leading cause of dings on your credit report. So if you look up your credit report and there's a ding on it, there's more than a 50% chance that ding is due to a medical bill, according to the Consumer Financial Protection Bureau. The overall costs of the US healthcare system are just really out of sight. We're spending 17 to 18% of GDP on healthcare. Other developed nations are spending about half that much. And all of these other developed nations do have some form of nonprofit national health insurance, or at least evolved through some form of nonprofit health insurance. A big contributor to the very high costs of American healthcare is the administrative overhead. The administrative overhead at private insurance companies, which runs 12% overhead versus only 2% overhead in traditional Medicare. But there's also the extremely high overhead at the hospital level. The average US hospital spends 25 cents of every budget dollar on billing and administration and paperwork, whereas in Canada it's about 12 cents on the dollar. I just saw a report that Cleveland Clinic says they can't possibly tell the government all of their prices because they have, get this, 210 million different prices. 210 million different prices in their letter that they wrote to CMS protesting why they couldn't post their prices. A study at Duke Medical Center, which has only 954 beds, found that they had 1,600 billing clerks. So we're not just talking about insurance administration, but about 13% of total hospital costs wasted on expensive billing, multiple insurers, probably a similar amount in physicians' offices. I am a physician, and I work with a group called Physicians for a National Health Program that does advocate single-payer national health insurance for the United States. And we have about 23,000 physician members. And people are a little surprised when they hear that doctors are supporting government health care. And one journalist made this joke, Physicians for a National Health Program, that's a little like furriers for animal rights. Nonetheless, I think doctors like myself are finding we really can't take care of patients because the patients can't get to our offices, because when we order things, the patients may be bankrupted, they don't want to comply with what we say, and because of the tremendous billing and paperwork that we view as a a big burden that takes a lot of our time and wastes a lot of our energy. Now, I have more to say, but maybe we'll get to it later, yeah.
Jim, you want to tell us what's wrong with the system that needs fixing?
Sure. From my perspective, I think the number one problem, there's a lot of interrelated problems, I should say, but the number one organizing problem here really is a lack of cost discipline. So there's no agent that is specifically involved in trying to discipline the system in terms of costs. So that means that the government isn't really in charge of disciplining costs. The states really aren't in charge of disciplining costs. And the market really isn't designed to be the cost disciplining principle. So given that, what you have is excess, waste, lots of inefficiency, lots of high pricing, lots of abusive practices going on. And I agree with many of the estimates about how much waste is going into our system. The question is, how does one bring some discipline to it? And really there is, basically there's going to be one of two choices. You either do it through a system where it's decentralized and there's a market mechanism to try to bring about some cost discipline, or if that is not something that the country wants to opt for, then you end up with a regulatory, budgetary approach that runs through the political process in some way. Most countries have opted for this latter approach. But there are costs to that. A lot of these nationalized systems have on-the-books costs that look very low, but there are off-the-book costs. That is, if someone has to wait for a service, they would rather pay sooner to get it sooner, but they can't. And that's not counted in the financial measure of how much it costs. Moreover, you can never really measure the quality of care that's foregone because it's not a measurable thing. You didn't know that that wasn't going to be invented because you don't have it. And so there's a lot of off-the-books costs, I would say, for a non-market approach. And that's the main trade-off here that the country has to think through.
Sherry, what's wrong? What needs fixing?
So first of all, I think maybe this is not a moment of crisis for the American healthcare system. So I want to start off by suggesting that this is actually not a moment of crisis for the American healthcare system. The biggest problem we have right now is that 17 states haven't expanded Medicaid, and they have uninsurance rates at the rate of 19% in Texas. But if you look at Massachusetts, which has been doing a pretty good job over the last 10 odd years, their uninsurance rate is below 4%. It's actually the same as the uninsurance rate in Ontario, Canada. So you can get your coverage numbers to look pretty good even under the system that we have. Does that mean that our system is perfect? No, it is a disaster. Our system is terrible in many, many ways. But it is not in crisis. It's a system that needs to be repaired. It needs a lot of fixes. But the main critical thing that needs to happen is that we need to get everybody in the health insurance system, and we have the tools to do that, particularly if states would expand Medicaid.
So I think the answer to my next question has been largely anticipated by what you guys already said, but I'm curious about whether you think Medicare for All is the right solution to the problems that you've identified, or if it is the wrong one. And I think I should just pause and give some idea of what Medicare for All is. We may, if you disagree, interrupt me, because I think it's a little bit of a political term of art that many people use to mean different things. So for the purposes of our conversation, I think we should think about Medicare for All as meaning a kind of single-payer system where everyone gets health insurance from the government and not from some private insurance company, and where that insurance is quite generous. People don't have to pay out of their pocket when they go to see the doctor. The insurance sort of covers the cost of their care. And under a proposal written by Bernie Sanders and endorsed by Elizabeth Warren and some other prominent politicians, it would also expand to cover services that aren't currently covered by health insurance in most places, like dental care, vision care, hearing aids, and residential and community-based long-term care. I'm sorry, not residential, but community-based, home and community-based long-term care. So let's, for the purposes of our conversation, let's talk about that kind of Medicare for All, which is sort of the Bernie Sanders flavor of Medicare for All. So is that the right solution?
Well, I'm pretty sure it's the right solution because I think it's the only affordable way to get everybody covered, not just with any old coverage, but comprehensive coverage. Because Expanding Medicaid would cover some of the poor people, but it's not going to help a lot of these working class families who have coverage, but the co-payments and deductibles are so high they can't afford to use it. So you need to both cover everyone and improve coverage so that people don't have those co-payments and deductibles. The way you can do that with single-payer Medicare for All is through the administrative savings that are really only possible with single-payer. The single-payer has administrative costs, insurance overhead of only 2%. Now remember I said private insurance is about 12%, but our own traditional Medicare program has 2% overhead. Medicare for All in Canada, also called Medicare, frankly, has overhead of less than 2%. So right there, you're starting with 10% of health spending that's available to you to expand coverage. Additionally, you can pay your hospitals global lump sum budgets, which is what they do in Canada. So you shrink down those hospital costs. You don't have Cleveland Clinic with 210 million price points and sending bills to collector in 210 million different prices. So you shrink down your hospital administrative costs, you shrink down your physician administrative costs. $500 billion a year are available in administrative savings. That's the money you need to cover 100% of Americans and to make everybody's coverage comprehensive enough that they can afford to use it.
Jim, you want to go?
Oh, well, I guess I'll go, and then I don't want to. I'll be short. Look, Medicare for all. No, I don't think it's the right solution. Just to run down things that have been obviously stated a lot already in the debates and in the media. The Urban Institute just did a study a couple weeks ago on the Medicare for all type approaches, single-payer type approaches, and at a minimum, it's going to raise federal spending by $32 trillion over a decade. That's with a 4-year, a certain amount of phase-in too. We've never experienced anything in our political process close to that. So, because obviously the current budget is about $4 trillion a year, so you'd be taking the current budget and just almost doubling it. And as was already indicated, we're not really in a crisis. So you have this massive shift in social policy occurring in a time when, yeah, there are lots and lots of problems, but it's not in a state of crisis that requires this massive upheaval that would be a part of it. There would be a very large tax increase associated with it. It would be offset to some degree by the premium savings people would enjoy from not paying into private insurance. But this would be a distributional question. And so everybody above about the median income or a little above the median income, if you're totally subsidizing people on the bottom half, everybody on the top half is basically going to pay twice, for their own premium plus the taxes needed to pay for the premiums for people that will pay nothing because they're not part of the tax incidence of whatever is applied. So you're going to have a very large distributional consequence associated with that, which has not been explored yet because nobody wants to say how it's paid for, because as soon as they say, someone will run the distributional analysis and half the country will be losers, okay, at least. The other part, to keep in mind here is we keep talking about universal coverage. I want to come back to this point because this is something I think, if you just look at the census data, we're at about 32 million, maybe it'll go up this year, 33 million people without insurance. But who are those people, right? We just had a debate 10 years ago that was very, very raucous, and the whole Congress is in upheaval for many years because of it, to pass a plan that I'm pretty sure President Obama said was on the way to universal coverage, if not universal coverage, right? So we passed a law not that long ago that was supposed to be pushing us well down this road. And when you look at the data, maybe he was right. It did push us well down the road in the sense that of the 30 plus million who are not covered today, the vast, vast majority of them could be covered. They're already eligible for Medicaid. Half of them are eligible for Medicaid, public insurance or publicly subsidized insurance on the exchanges. Another 5 or so million have employer-sponsored offerings that they decline. Another few million people are above 400% of the poverty line and just forego insurance and become self-insured. There are two groups that you should keep in mind. First one being those who are in the Medicaid states that haven't expanded. Now that's going to be at most about 3 million people. who are below the poverty line, ineligible for Medicaid, and ineligible for the exchanges. 3 million out of 330 million, okay? That absolutely needs to be fixed. Those people don't have a good insurance option, which is a huge problem and needs to be closed. But that's not 330 million. And then the other big group are the people that are in the country without proper documentation. Now, sometimes it's, I think, because of President Trump and his horrible rhetoric, don't get me wrong here, but sometimes I think it's the thought the Republicans force the Democrats not to cover these people with the affordable. That's not true. They passed their own provisions saying that those folks would not be eligible for Medicaid or the publicly subsidized insurance coverage for all the reasons that, you can come, every other country with a nationalized system does something similar. By the way, if you're in the UK and you're not there with proper documentation, you can't just go into the National Health Service and get full benefits. Same with Canada. So it's for legal, immigration reasons. So I think we should be careful about this 30 million number because there's a lot of reasons why people are not covered in that group that probably, some of those same reasons will still apply even under single payer. I think I'll stop there.
Well, I just want to come back to one thing, which is you identified the big problem as the costliness of the system, and it sounded like you thought a government-administrated plan is one good way of tackling that, maybe not your preferred way. Do you think that single payer, that a Medicare for all kind of plan would address that particular concern that you have?
Well, as I said in my first remarks, anything where you have a regulated payment system, which is what would happen with single payer, Medicare for all, you will have on the books, almost undoubtedly, you'll have on the books lower costs. Because the government usually, I'm not saying it's always going to be the case, but usually will have some budget constraint and they'll just say, this is what we're paying and no more, so be it. Take it or leave it kind of thing. That's certainly the way it applies often in Medicare. I think that that's not the way to go. I'd rather have a market disciplining system where you get the right price for the right products and the right services so that people can pay what they want for things that are highly valuable and don't have to pay so much for things that are not so valuable. And so, if you don't have a market mechanism, discerning value across different items and services is much harder, and the government is, going to be very blunt force in that regard.
Okay. So I want to actually take this in a different direction, and I actually think this is a question that's best addressed not in terms of health policy, but in terms of public policy or progressive policy. And I think in those two terms, single payer would be a disaster for the United States. And let me explain why, and I'm going to wonk out, so be prepared, okay? So one of the things I think you should note is that around the world, every other rich country besides us has a universal health insurance system. None of them has a system that looks like the single payer system. Not one of them. They all have systems that are substantially more fragmented than the system that Steffie described. And that's interesting because some of them have had those systems for over 100 years. And they keep fixing them. They renovate their systems every 2-3 years. Healthcare is not a one and done thing. Germany is constantly, they got health insurance under Bismarck and they're still fixing it every few years. So they keep fixing their systems, but they don't move in the direction of single payer or even in any other specific direction. There's no obvious answer to which of these systems is the best.
Well, there's Canada, right?
Canada is not a single payer system. I'll be there in a minute.
Well, doctor.
Well, hang on.
Okay.
No, okay. You're just let me give me my time. I'm Canadian, so I know the Canadian healthcare system very well. Thank you. Hold on. All right. Okay. So they all have different systems. They are all much, much more fragmented than ours, and they are persistently more fragmented than ours. Now, why is that? I want to hold that to the side, and I want to do a little math. Ready? Okay. The annual budget of the United States is about $4 trillion. Of that $4 trillion, about $950 billion is Social Security, and about $300 billion is the national debt. So there's about $2.75 trillion a year that Congress decides how to spend. Okay? Of that sum right now, about $1.2 trillion is federal health care spending. That's about 44% of the total. But it kind of overstates the congressional role because a big chunk of that is money that goes to the states. The states run the Medicaid programs. They set all the rules for the Medicaid programs. If we take that out, the money that's actually in the control of the federal government is about 30% of total the total US budget right now. So US healthcare spending as a share of the total US discretionary budget right now is about 30%. Everybody got that? Okay. So what happens under single payer? Well, you just heard there are different estimates. We could talk about, before I go on, health is the number 5 largest sector in terms of campaign funding and lobbying. Most of that is healthcare professionals, not health insurance companies or pharma. They're also, before I go, I'm interrupting myself, I'm sorry. The healthcare industry has structural advantages in terms of political power that would be the swooning envy of the defense industry. In over half of US congressional districts, the number 1 employer is the healthcare sector, in over half. And speaking as a former regulator, you have never been lobbied until you have been lobbied when you're wearing a hospital gown and sitting on an examination table. So there are structural advantages of the healthcare sector in terms of reaching government that are consistent with its very substantial role already in the US government. It's a big enough role that the democratically controlled House right now cannot bring itself to pass legislation ending surprise billing, even though it's democratically controlled. So healthcare is already a very big player in the political marketplace. Now let's just talk about what happens under Medicare for All. There are a bunch of different estimates of how much it would cost. The more liberal, progressive people estimate that maybe it would increase federal spending by as much as $1.5 trillion. The Urban Institute, which tends to be right about these things in the past, says $2.8 trillion. I'm going to split the difference and go with 2.1. I'm just splitting the difference. You can change the numbers if you want. So let's say it's $2.1 trillion.
Let's say it's nothing. Let's say it's the same
No.
price. No.
Federal budget.
Oh,
federal budget. I'm not talking about national spending.
Not about national spending.
Not national spending.
Yeah.
I don't care about national spending. It's an irrelevant statistic. Talking about the federal budget. Okay. $2.1 trillion. Right now, I said we spend 1.2. Add 2.1 to that. We're going to collect all that money. It's not going to be deficit finance, so we're going to add 2.1 to the denominator as well. So what share of federal discretionary money will healthcare be when we implement the single payer plan? 70%. The US government, the Congress, the executive branch of the United States will be a giant health insurance company. 70% of what they do will be the healthcare system. Everything else will be 30% of what they do. Defense, research, NASA, everything else you'd like in the world is 30% because 70% of the business of the federal government will be healthcare. It will be a giant health insurance company. Now, imagine what that does to the institutions of the United States. Imagine who runs for Congress and what the debates in the House and the Senate look like when pretty much all that the Congress is doing is healthcare. Now, I told you that all the other countries in the world have, rich countries in the world have universal health insurance systems. Why don't they have this problem? In none of those countries is the federal share or the national share of health spending higher than 25%. How come we're at 70 and they're at 25? Steffi told you we're twice as expensive as other countries, not 3 times as expensive. Well, there are 4 reasons for that. One is that healthcare in the US is unusually expensive and would continue to be so even under the more progressive healthcare reform proposals. That's number 1. Number 2 is that the US has very low social spending in general, so our denominator is quite low compared to other countries. But the other 2 are design choices. One is we have a federalist system. Other countries that have federalist systems and run single-payer plans run them in their federalist system. So Canada does not run a single-payer plan. In Canada, the federal government provides block grants to the provinces who each run their own health insurance system, quite independently and quite differently. In Quebec, for example, drugs are covered, and in Ontario, they are not covered. That's a pretty substantial difference. Quebec uses something more like HMOs. Ontario has global budgets for hospitals. They don't run the same way because they are not run by the federal government at all. Other countries, instead of that don't have federal systems, in the Scandinavian systems, the counties and cities actually put in a lot of financing for the healthcare system, and they have both responsibility, financial responsibility, and accountability as well. Nobody is running a system that consumes 70% of their government because it's bad public policy. Not bad health policy, not bad in terms of administrative costs, just bad public policy, because a lot of other things are really important besides the healthcare system. And if you let healthcare be 70% of your government, those other things are going to disappear pretty darn fast.
Well, I disagree with so much of that. Okay, the money, okay, first of all, healthcare spending in countries with national health programs is half of what it is in the United States. A single payer is not going to take us down to half, but it's not going to boost our spending either.
But it will
We're
boost
going to
our
be able,
spending.
let me finish, I'll let you finish, okay? It's not going to boost spending. So when we're talking about this huge amount of money, this is money that we're already spending, only now we're spending it on premiums and co-payments and deductibles. And when I pay a premium, it's a tax in everything but name. I have to pay my premium. You know, my employer is going to put money into it, and they don't give me the money back if I say I don't want health insurance. You know, I get in really big trouble if I don't have health insurance. So we're paying this. We're not calling it tax, we're calling it premiums, but we're already paying it. You know, so when the government decides to build a bridge, it's taking money from something else to build the bridge. When the government decides to provide Medicare for all, it's taking money we're already spending on health care and just shifting it through the tax system. So don't believe for a minute we're going to be spending more. And frankly, the Urban Institute paper was just terrible. They assumed virtually no administrative savings. Even though Medicare and the single-payer system in Canada run for 2%, they decided off the top of their head that their single payer was going to have insurance overhead of 6%, 3 times as high. They decided off the top of their head that even though Canadian hospitals run at half the overhead of US hospitals, 12% versus 25%, there was going to be no administrative savings in hospitals in the United States. They did the same with doctors. So they modeled, and then the final thing they did is they modeled huge surges in the use of doctor visits and hospital care. 20% increase in hospitalizations, 20% increase in doctor visits. Where are all those doctors going to come from? We could have 1 million doctors a day before we get Medicare for all and 1 million doctors afterward. And they're all busy. None of them are underemployed, okay? So we don't have the capacity for that kind of surge. So the Urban Institute study was ridiculous, frankly. And they have a good reputation, and people paid attention to it because they've done good work in the past, but it has no relationship to reality. And in fact, the Mercatus study, which is a very conservative right-wing think tank funded by the Koch brothers, they were closer to the mark, saying, you know, after you get to single payer, you'll be about level funded, at least initially. Maybe you'll save a little bit, but there's no surge in spending. The Urban Institute figures are frankly, don't hold with what's happened internationally and what other people have been saying. Now, is there a crisis right now? You bet there's a crisis. I mean, I'm a doctor. I see patients in the South Bronx. Patients don't come in to see me because they can't afford it. I prescribe medications, they don't take their medications, okay? We happen to know from data, you don't have to accept this anecdote of me, what my practice is like. People who have to worry about co-payments and deductibles delay going to the hospital when they get the symptoms of heart attack. Okay, we in medicine, we go time is muscle, time is muscle. It means when you have a heart attack, you have to get to the hospital right away for clot buster drugs. But you're 20% more likely to delay going to the hospital if you're underinsured, you have a big deductible, and 30% more likely to delay if you're uninsured. Time is muscle, you've lost that muscle. Ladies with breast cancer who have high deductible plans delay definitive therapy for 8 months relative to ladies who don't have a deductible. That is a disaster, that is a crisis. And in people who have myocardial infarction, they need a lot of drugs to prevent the next myocardial infarction. But among minority patients who have low incomes, if you put high co-payments on those drugs, you will increase their rate of recurrent myocardial infarction. That is a crisis. Okay, that's not something, okay, that we're going to fix by offering 9 million people Medicaid, even though we should. Medicaid expansion would offer 9 million people Medicaid. That's not something that needs a tweak. That's a crisis. And we see it overall in what's happening with life expectancy in this country. Life expectancy has not increased in the United States in the past 7 years. Every other developed nation keeps living longer and longer and longer year upon year. But in this country, and in this country alone among the developed world, there's been no increase in life expectancy over a period of years. Now, only part of it's our healthcare system, part of it's our lack of other social services, but the fact that people can't afford to get healthcare when they need it is a contributor to why we're falling off the curve, whereas other developed countries are continuing to improve.
So I would just say that the Urban Institute thinks that there's going to be an increase in utilization because it thinks that when you take all those underinsured people and you give them coverage, they'll go get their heart attacks treated on time and all the other stuff that you said. If you don't believe that there's going to be an increase in utilization, then why do you care about covering them?
Okay. What has happened, and we just published 2 studies on this, one in the Annals of Internal Medicine looking at hospital care, another in the American Journal of Public Health looking at physician care, where we tracked the number of hospitalizations in one case and physician visits in the other before and after the 2 largest coverage expansions in US history, the Medicare expansion in 1966 and the Affordable Care Act expansion in 2014. And we found that previously un- and underinsured people did increase their use, but this was fully offset by small decreases in utilization among people who were more affluent and better insured. In fact, the decreases were so small, nobody commented on or noticed them, but you can pick them up in the data. It appears that low-value care, unnecessary or low-value care that we all know is very frequent in the U.S. healthcare system, that went down in the previously well-insured population. So
you're also going to drop everybody's copays. You're not just affecting the uninsured, you're actually going to take all those people out of high deductible plans and all that other stuff, so.
Certainly many people with the Medicare expansion, about half of those folks, in fact, had some sort of coverage before. In that case, you were, in fact, improving coverage for people as well.
So we've talked a bit about what the effect of Medicare for All would be on the uninsured, and we've talked some on the underinsured. We've talked some about what the effect of Medicare for All would be on the federal budget. I'm curious if you guys have thoughts about what it would mean for the healthcare system itself, how the system might change, what pressures it would face. You mentioned the idea of paying hospitals on a global budget. That's a really big change in the way that we pay for medical care. Jim, you mentioned some concern that maybe people would have to wait for things, or there might be challenges in the development of technology. Just as you think about this question, what happens under the hood of the healthcare system? If we could sort of overcome the political challenge and the fiscal challenge of paying for this, we get all these people into one system, the government is paying for all this stuff. What does that mean for the provision of healthcare and the structure of the healthcare system itself?
There's a couple of things that probably should be said here. One is that, I'll get to your question specifically, but we've got to cover one more thing about all this, which is that when we talk about Medicare for All, the Sanders plan and the companion bill in the House, they would get rid of, obviously all private health insurance, they get rid of all copays, all premiums, all deductibles. And that means getting rid of all employer-based health care, right? So for the 160 million or so people that are working, getting their insurance through their employer, basically that would no longer be an option. You'd have to go into the government-administered plan. Further, even in the Medicare program, this is ironically called Medicare for All, but Medicare's had since the early 1980s a private insurance option, which is now 1/3 of the program. There's 22 million people who have elected voluntarily on their own to take a private insurance option for getting their Medicare benefit. By the way, they also supplement Medicare with a lot of private insurance too. And all of that would be gone. So you'd have to sort of, ask yourself politically, does it make sense that you could, get away with it and B, even try to get rid of all that coverage and tell people, well, we're going to give you a strictly Medicare-run benefit now, and you can't take that Medicare Advantage plan anymore. Very, very unlikely. And also, just frankly, the 160 million people on employer coverage. I think that's also very unlikely. So in addition to this massive change in the fiscal stance of the United States, you'd also have to undo a lot of entrenched systems, which is why when you look around the world, they have a lot of co-payments. They have a lot of premiums. They have a lot of deductibles. There are exceptions to those rules, but that's not the preponderance. They pay deductibles in Scandinavia, and cost sharing, and premiums, and there's private insurance.
Nobody pays a deductible in Canada. There's no copay.
No, in
for
Canada,
deductible
I said there are
for
exceptions.
hospital care physicians.
But if you look
They don't have
around,
any drug coverage.
you look around the industrialized world, rich countries, they are not wholesale getting rid of all these things. And then you have to ask yourself, why don't they? Well, there's a level of responsibility that they expect from their citizens as well. So you don't have to do a wholesale single payer to try to treat the people with modest incomes better. We could do that without an entire single payer plan. And then to the specifics of your question, what would happen? I think one good example of what would happen in our political system and how it operates and the institutions we have Medicare physician fees. It's a hugely complex, messed up system, okay? And they used to have it on a budget, something called the sustainable growth rate. It was on it for about 20 years, okay? It didn't work very well, okay? So they had to get rid of it. And they got rid of it, and the physicians would lobby Congress every year to get rid of it, and they did get rid of it. So now the physicians are on a system that is promising them in perpetuity that at best, if they're participating in the right system, they might get a 0.75% increase in their inflation update per year under the Medicare system, not counting some of this complex quality stuff that they're trying to add on, which is also a big mess. If they don't participate in some of the stuff they're trying to push them into, they get 0.25% increase. Not just 1 year, every year, forever. That's all they'll get, okay? So cost cutting, why did they do that?
Can I interrupt for 1 second just to say that physicians under Medicare, it's not like they're paid a salary where this is a guaranteed salary increase. They're paid a price for each service they provide, and this is an increase in the
But on single payer, this would be their entire salary. This would be all they get, all through one regulated system. And
if they want to earn more, they have to work more hours.
or have to perform more services.
Okay.
Or more expensive services, maybe.
They have to perform more services, which is probably what they would do. So my point basically is this. In our political process, when Congress has got to meet a budget, and they have to hit a target in terms of where do they want to get total spending, they aren't going to have some refined, nimble way of paying for everybody. It's going to be a blunt, across-the-board system, just like they apply in Medicare, which most physicians find maddening and not very good. And so I think the idea that we'd have this nirvana of a single payer with the government designing this perfect way of paying them that everybody would be happy with is really just defies all experience in our current political process.
It's very hard to imagine exactly what the world would look like under a single payer plan at this moment. Canada is probably the closest in terms of hospital and physician payment that we've seen. It's the model that is used. They've changed a lot of what happens within Canada, and the provinces do vary among each other. So one of the things that's really interesting, actually, if you follow international health policy, for example, is that global budgets have actually receded in importance. Fewer countries are using those. Most are moving, including Canada, to adding some activity-based budgeting to try and get the hospitals to have more throughput. I think that what you would see over time if we move to a system like Canada's is probably less organizational innovation in the healthcare system, which might be a good thing or a bad thing. So
what's organizational innovation?
So walk-in clinics, telemedicine, those apps that you can now do on your phone and talk to your doctor. Outpatient surgery took a very long time to get started in Canada. That's a pretty typical situation in a heavily regulated system. Existing entrenched interests protect their own, and it's hard for new entrants to get into the system. One of the consequences of that in Canada, interestingly, is that although everyone has coverage, they have even higher rates of emergency room use among people who can't get in to see their doctor than we do in the United States. Why is that? There's very little after-hours care. Doctors are not terribly responsive to their patients. It's fine. It's better than we have. Honestly, I would rather be in the Canadian healthcare system than in the US healthcare system. But it is far from certainly if you look at rankings of the best healthcare systems in the world, Canada is never one of the ones that makes the mark. And that's part of the reason for it. So I don't think, I also don't think, however, that we would get to Canada. And why not? well, I actually did these numbers a long, long time ago, so I don't remember them very well. But there are more millionaires on the island of Manhattan, I think, than there are in all of Canada. Actually, many more millionaires on the island of Manhattan. Millionaires probably don't even need health insurance, or they could buy something else. One can easily imagine systems of care arising for people who don't want to wait in line, don't want to have the restricted choices. There's actually been lawsuits in Canada. The Canadian Supreme Court has actually ruled that you should be able to buy private insurance in Canada. There isn't much of a market for it there, and that's partly because it is a less unequal society and it's more spread out over the area around the American border. I don't think that would happen in the US, and I actually think that's unfortunate. One of the problems with having all the rich people in the system is that the system becomes quite responsive to the rich people. And one of the things that we've learned about healthcare around the world, and actually this is data from the OECD from other countries, is that rich people and poor people use healthcare systems quite differently. Rich people use a lot more specialty care. They use a lot more elective care. They are more aggressive in using new technology. It's a function of the social networks that they have. It's true in Norway. It's true in Sweden. Poor people use more inpatient hospital care. They use more primary care. One of the reasons that most countries, Canada the exception, allow the richest people to opt into private insurance is because they don't want that pressure to be adding the robots and the high rapid access to surgical care and all of those other things to the tax base. They want to let people, if people want to pay extra for that, it's fine with them. They want to make sure that tax dollars, which are after all really precious dollars, really costly dollars for the government, that you take those dollars and you put them to their best, most progressive use, that you use them to really provide care to poor people. So by actually letting the rich people out of the system, you can, in fact, make sure that poor people are getting more of the tax money.
Okay, I feel there's been a mischaracterization of the Canadian system. For hospital care in Canada, you cannot buy private insurance that competes with the National Health Program. That's against the law, okay? Now, you can pay privately all you want. You can move to Florida or wherever and pay privately. But there's not private health insurance in Canada that competes with hospital coverage. Similarly, there's not private health insurance in Canada that competes with the doctor coverage, which is available to everyone without copayments and deductibles.
Although it's not illegal.
I am not sure.
There was a Supreme Court decision. It's not illegal.
Okay, it hasn't emerged. Okay, it was illegal. The Chiuli decision in Quebec said you could have it, but it hasn't emerged because it makes no sense. Okay, so everybody's on the same lifeboat when it comes to hospital care and physician care. All right. There are things that aren't covered in Canada. Drugs aren't covered uniformly. Long-term care is only covered in some provinces, not other. But for the doctor and hospital care, literally everyone is in the same lifeboat. And that's very important for the quality of care available to everyone, frankly. If you put the poor in one lifeboat and the rich in another, the lifeboat for the poor is going to have leaks in it and no one's going to bother fixing it. But if the richest woman in Canada has to get her care the same place as poor people, that lifeboat is going to be kept in very good repair. In Canada, the only thing that people really buy substantially is supplementary coverage, which would have to be allowed in the US Medicare for All system as well. Probably the Supreme Court won't let you outlaw it. But supplementary coverage means for things that are not covered by the National Health Program. So drugs in the places where drugs aren't covered, private rooms. So Canada, at least the hospital and the doctor piece of it, really do work as a single payer, single system. You know, Canadians live 2.5 to 3 years longer than Americans. There's a lot of factors involved, but prior to their National Health Program implementation in the mid-60s, it was not true. Canadians had shorter life expectancy than people in the United States. You know, Canadian doctors, if they want, can move and practice in the United States. They don't. they stay there because the conditions of practice are actually quite good. The salaries are okay. The Canadian doctors protest every time they go to negotiate their fee schedule with the provincial government. Oh, we're not getting enough money, give us more money, we need more money. But at the end of the day, they end up with enough money that they decide to stay and not leave. So, you know, we can talk hypotheticals, oh, it's so complicated, it's so difficult, we can't possibly figure out how to do it, the rich people would all rebel. Or we can talk about the real world experience in Canada, where the rich people really haven't rebelled, the doctors haven't rebelled, they did a transition in their hospitals away from fee-for-service to global budgets. They did a transition with the doctors where they used to bill privately and now they have to send all their bills, you know, to the provincial insurer. This can all happen, and don't for a minute believe people who tell you we're just too stupid or too incompetent or too selfish in this country to do what they can do 300 miles north of here in Canada. It's not true. They're just like us. Their doctors think like us. Their medical care and their science is like ours. They figured out a way to do it at a lower cost and cover everyone. And that's actually what's being advocated this year in the presidential debates. And
so why Canada and not Australia?
well, okay.
Australia, they live even longer than Canada.
Okay. I tend to talk about Canada because I'm a physician and we have one medical practice system that covers Canada and the United States. When I go to the American College of Physicians to debate about single payer like I did last month, right? People in the room are from Canada because half of the chapters, not half, 10% of the chapters of American College of Physicians happen to be in Canada. So I work a lot with doctors, that's our Physicians for a National Health Program work and the American College of Physicians work. So it's very easy for me to explain to American doctors how their life would work under a Canadian-style system. The Canadian folks always stand up and say, well, you know, we don't get everything we want, but it's not so bad for doctors and it's much better for patients. So it's not rocket science. We don't have to reinvent the wheel. There are good systems in place, not perfect, but good systems in place that we can borrow. Finally, Canada's only spending half what we are, okay? I'm not advocating, and I don't think anybody who's smart would be advocating taking the money we're now spending, $10,000 per capita, and immediately cutting it to $5,500 per capita like they spend in Canada. We're going to take a Canadian-style system, but at least initially have the level of funding that we have in the United States. So why are there going to be shortages? Where are these shortages going to come from? You know, why are there going to be waiting lists? Okay, maybe we had $5,500 per capita to spend to be waiting lists. If you take that system with $10,000, why would you have to have a waiting list? I think that's really scare tactics about the waits. I think there's plenty of money to provide, it's $10,000 per capita to provide excellent care, not just for the waitress and the cab driver who took care of you today, but for those of you who have upper middle class and even higher incomes. There's plenty of money there to take good care of you.
So I know that there's a desire to keep going, and I have lots of questions too, but I want to make sure we have some time for some audience questions as well, and I know you have been standing there for a long time. So I just want to warn everyone who has a question that it must be a question, and I am an extremely mean moderator, so if you just start rambling, I'm just going to cut you right off. So go ahead.
Well, thanks for that warning, because it's hard to sit in the room, someone who grew up in the UK, but who's lived in the States for the past 30 years, and on top of that is an HR professional who negotiates health benefit packages. So my question is this, and I'll try for the answer not to be in the question. To what extent do you think that a modeling of the single-payer system on the British National Health System, the NHS, stands a chance of working in the United States?
So I'm going to just start by answering part of that question, which is just explaining. So the way the British system works is it's not just that the British government is the health insurer, like what we've been talking about in a Medicare for All proposal that is under discussion in this country, but the British system is also owns and runs the hospitals, employs doctors directly. So the British system kind of the government actually runs the healthcare system, is not just the health insurer. Does that strike you as the important distinction?
Yeah.
That you're asking about?
That's part of it. Remember I said I'm trying not to put the answer in the question. I do want to throw out there a little known fact, because this touches on the cost of healthcare, which I think we do need to focus on. 60-something% is spent on staff costs. 20-something% is spent on prescriptions, and the other 20% buildings, and so on and so forth.
So we don't really have any politicians in the United States that are talking about moving to a British-style system, a more, a system where the government is really controlling the entire health system. What do you guys think about that idea? Should it be part of the menu of things that we're talking about?
No. Look, I mean, I think one thing we should keep in mind here is that the United States is, we're 5 times as big as the UK. We're 10 times as big as Canada. There are lots of reasons why we have health differences with both countries. The United States has a lot more social questions that actually spill into our health system. We have more trauma in our hospitals. We have more car accidents. We have lots of things that end up being dealt with in our health system that other countries don't have as to the same degree. And it gets factored into how we measure all of these things. It also factors into, frankly, our mortality rates. Plus, we have a totally different political system than the UK. We don't have a parliamentary system, and it's not, it would be very difficult to imagine moving our entire system into some kind of A, single payer, or B, one where the physicians and the hospitals are kind of directly owned, so to speak, by the government itself. So I really think it's a bridge way too far for the United States at this point in our history. Maybe in 1950, it would have been a possibility. But we have a big, mature system, right? So you're going to tell Sloan Kettering that their entire budget is now globally set by Congress working with the Medicare Payment Advisory Commission, right? I don't think they're really going to like that. I don't think that's also true of, the major teaching hospitals in Chicago and Boston, Los Angeles, and everywhere else. And they're not going to sit by and just say, yeah, we'll take a big 25% reduction in our capital budget. So
there won't be a reduction in total budget because total spending will be the same, right? They have less administrative costs, but they're expected to provide more care.
Oh, to be fair, though.
But it's the same budget. It's the same trillion-dollar budget for hospitals.
No, it is the same trillion-dollar budget for hospitals, but the division among, the division among hospitals will be different.
It would
so
be.
Right now, 23% of hospitals are paid more by Medicare than by private insurance. They will do very well. 75% of hospitals in New York State are paid less by Medicare than by private insurance. They will do poorly. So there will be a change in, some hospitals will do much better than others.
But the simple answer is no, we're not advocating a British-style system. It's got some pluses, but it's got plenty of minuses, and politically, no one's advocating
Okay,
it
thanks.
now. Yeah.
All right, next question.
So I observed that the 3 panelists actually did agree on something, which is that our system, there are better systems around the world than our current system. That's what I heard. And for the 2 panelists on my right, I wonder if you could talk a little bit about how you see, just briefly, how you see improvements to our current system if it's not Medicare for all.
I'll go very brief because we've got 6 people behind you there. So I think we need a more, if we're going to have our diverse, decentralized system, which I would favor us having, we need to also bring much more discipline to it. So at the margins, everybody should be in the system, everybody should have insurance coverage, but on the margins, there need to be some incentives to buy high quality, lower cost care rather than high cost, low quality care, okay? That's a simple principle, but needs to be applied in a lot of different dimensions. It needs to apply in the employer system. It needs to apply in Medicare. Those 2 big ones, just start there. You need to do that. And how do you do it? Well, the subsidization system shouldn't be open-ended. That means, we'll subsidize you into insurance coverage, but only up to a certain limit. Above that, you pay a little bit of your own money, okay? It's way more complicated than that, but you have to replicate that principle 100 times around our system in a lot of different dimensions, and it would start to have an effect.
So I guess the system that probably I would like the best is something like Medicaid for all, which is not Medicare. That is to say that there is a safety net system that everybody can be in if they want to be in it. It's actually open to anyone with income-based premiums. And people who want to buy other coverage can have it. That's more or less the system in Australia, where about half the population is in that baseline system and the other half of the population buys their own coverage. Seems to be really effective. People are very happy. They get access to care and costs are low and life expectancy is high. So a split system, I think it's really essential that we provide everybody with basic coverage, but I think you can't fix the problems of income inequality in the United States in the healthcare system.
Thank you.
Is your answer Canada?
Yeah, well, okay. I think, I do think the answer is single payer Medicare for all like Canada, and I think the problem with the Medicaid for poor people and private insurance for rich people, twofold. You have a two-tiered system, okay, with poor quality care for poor people, and it's much more expensive because you leave the private insurance industry in there with all of their waste, all of their overhead, all of their profits, which sucks really hundreds of billions of dollars out of the system. And that money you could save under a single payer and use it for care.
But if people find it so expensive, they'll just go into Medicaid.
Okay, but then they're accepting a poorer quality. Particularly access to specialists is extremely bad with Medicaid. You can find primary care doctors such as myself will take Medicaid, but just try getting in to see a specialist with Medicaid in this city, okay? It's almost impossible. So I don't think that's acceptable, that poor people should be denied access to orthopedists, that the next appointment for an orthopedist at Mount Sinai is 7 days if you're privately insured versus 7 weeks if you're Medicaid. That to see an oncologist in this country can take you months if you have Medicaid versus almost overnight if you have private insurance. That to me is unacceptable, and we need everybody in the same system.
All right.
Thank you so much. I am from Germany, where we have universally available healthcare, and it's, to me, it almost seems like a human right. It's something very natural everyone has. So coming to the US, that was a big cultural shock to see how much people pay for it. And that's why I asked many people about how come the health insurance is so expensive here. And I had one justification, which I would like to test with you or get your view on it, which was that essentially the US is subsidizing international healthcare, which means pharmaceutical companies, once they innovate or want to develop a new drug, they calculate in the revenues they would get from the US, which are much higher, given we heard that health insurance is double as expensive as anywhere else. They would factor this in and then make a decision to innovate or develop a drug based on the revenues they get, where the US makes a big part of it. So essentially drugs, if the US would reduce its prices and also the revenues towards pharmaceutical companies, there would be less drugs that could be developed, which would then also not be available for the international community. And since I didn't have a direct answer to that, I would like you to comment on it. Thank you.
Can I refine the question slightly, which is, I'm curious, first of all, whether you guys agree with that in the pharmaceutical sector, but then also whether you think there is a similar effect in other parts of our healthcare system. Is our doctor care more expensive? Is our hospital care more expensive because we're somehow subsidizing the rest of the world, or is it some other reason?
Okay, it's clearly not true for doctor and hospital care. There's nothing that doctors or hospitals in the United States do that subsidizes the rest of the world. In terms of the drug industry, that argument has been made by the pharmaceutical industry in this country in order to support the idea of the extremely high prices that they charge. Now, I want to tell you that they charge $1,000 a month for insulin in this country. Insulin was an old drug when I was in medical school. It's not a new drug. It's not an innovation. It's just a drug that's necessary for life, and they've exploited that fact to charge people $1,000 a month for insulin. So, okay, maybe some money needs to go for innovation, but that's not the way to pay for it. The way to pay for it is by paying through things like the National Institutes of Health or tax-funded research, not paying them $1,000 a month for an old drug like insulin and counting on them doing some innovation.
I think this is a part of the answer is yes, it is part of the reason why systems in Europe and Japan can be slightly less expensive than the United States. It's not the predominant reason, but it is one of the reasons. If you just look at product launches and research and development activity, and you measure it in a lot of different ways, more or less, roughly 2/3 of the new stuff coming online over the last couple of decades and going forward, the expectation is the same, basically is starting here in the United States. And that, as soon as it happens, it gets disseminated globally, okay? That's a good thing, okay? It's not the entire health system, though. It's 15 or 20% of the system. So it explains some part of it, but not a big part of it. A big part of why we have differential spending is physician salaries. We pay our physicians an awful lot more in the United States. They're not regulated, okay, like they are in most other countries in some indirect or direct ways. So, that you have to ask yourself the question, is that a good or a bad thing? We're paying our doctors a lot more. Is that good or bad? Might be a mix of both, okay? And so I think those are some things to think about.
Let you go first next time.
whatever.
Yeah.
All right, so I think this is our last question, so
boy.
make it a really good one.
Oh, so much pressure on me. Hi, my name is Sulin Bu. I'm editor-in-chief of Code Blue, which is a health news site based in Kuala Lumpur, Malaysia. So Malaysia is near Singapore, in case some of you don't know where that is. We are an upper middle income economy, and we have a dual healthcare system. So what I mean is that we spend about 4.5% of our GDP on healthcare, and they are split more or less equally between the public sector, which is tax-based financing healthcare system, and the private sector. What I wanted to ask was to get the panel's opinion on medicine price controls. So in Malaysia, the government mostly buys generic medicines, right? So innovative medicines are mostly available only in the private sector. So my government wants to impose price ceilings they are targeting 400 molecules, so mostly innovative medicines. So they want to impose price ceilings at the wholesale level and at the retail level. So of course, the pharmaceutical industry is against this. A lot of pharmaceutical multinational corporations have told Malaysia that this would probably affect their investments into Malaysia. And then for other players in the industry, like general practitioners in Malaysia, their consultation fees are regulated by the government. And they have been at the same rate since 1992, and their consultation fee rate is actually $1.25 to $9 US. So the maximum general practitioners can charge in Malaysia is $9 US. Yeah, consultation.
So what is your question?
So my question is, what does the panel think about medicine price controls? Because in Malaysia, they want to do it. They are telling businesses that if they violate medicine price controls, if they are implemented, then they're subjected to fines or incarceration. So do you think that that is a good way to reduce healthcare costs? Thanks.
Okay. Obviously, the bargaining position of a single payer in the United States with vis-a-vis pharma is going to be very different from Malaysia's bargaining position. So if a single payer in the US says to a drug company, you have to lower the price of insulin, the drug company can't say, well, we're just going to pull out of the United States and not sell insulin anymore. And so we're really in a very different situation. Most developed countries do use some form of price negotiations with pharma, and to my knowledge, they've never been threatened with a drug company abandoning them in the developed world. I know you're developed world, but in the affluent part of the developed world, most affluent part. Yeah.
I don't think that's true, and there's a lot of studies that show that at product launch, drug companies are strategically withholding their launches in some countries by 2-3 years, especially in the oncology space, because of the pricing effect it might have on their ability to get the prices and revenue they want in other countries. So for the smaller countries...
You think that would operate in the U.S.? Would that happen to the U.S.?
No, I don't think it'll happen in the U.S.
That's the point. It's not going to happen in the U.S.
Yeah, but I think it will happen in a smaller country that doesn't have the market share. They do and have shown and do withhold products from time to time. Not always, but they have done it. There are a lot of studies showing that they have.
I want to thank our panelists especially, but all of you for being such an engaged audience, for asking such wonderful questions. I'm sorry that we ran out of time, but I have a feeling that if you want to come up and talk to us now, probably ask your question briefly.
Be over on the side. Thank you.